Good morning, everybody. This is a lecture on automatic exposure control, and this lecture is coming from your Bushong book, chapter 13. Also, Carlton chapters 32 and 33. So they're just all mixed together because we're just going to go through automatic exposure control, how they are made, and what the primary factors are when using them. Okay? So a brief description is it is a system used to consistently control the amount of radiation reaching the image receptor by terminating the length of exposure. So that's important. The main thing that the AEC does for you is time. It times the radiograph for you. Okay, so, and we're going to go through how it knows when to terminate the exposure and how you can override that and things like that, okay? So how that termination happens is the radiation is transmitted through the patient when you press the exposure button. It goes through the patient and then it's converted into an electrical signal after it exits out the patient, sometimes after it's been through the IR already, sometimes before, and we'll go into that. It's converted into an electrical signal, and that signal is what tells the AEC system to terminate the exposure. Okay, so there's a predetermined level of radiation that must be reached before the exposure is terminated, and that has all been programmed by the engineer that's installed the system. There are two types of AEC systems. Those two types are photo timers and ionization chamber systems. The photo timer is shown on the picture on the left on this slide. It shows that radiation wave is going through the patient. It is also going through the image receptor before it hits a light diode. Okay, and they are called light paddles. The light paddles, together with a photomultiplier tube or several of the tubes, measure the exposure after it passes through the IR and then terminates the exposure when a certain level has been met. Okay, the second type is an ionization chamber system. And the chamber system measures radiation exposure before it even reaches the IR, but it's timed appropriately so that there's sufficient exposure on your IR before the exposure is terminated. Okay, the first type, the photo timers, they use light paddles. Those light paddles are coated with a fluorescent material, and they serve as detectors. And you've seen this type of engineering before in your IRs, okay? Same type of thing. The radiation interacts with the paddles. It produces a visible light. That light is then transmitted via remote photomultiplier tubes or photodiodes, depending on the manufacturer, and which convert the light, that visible light, into electricity. The electricity then trips a timer, and then the exposure is therefore terminated. Okay, soon, and that's pre-programmed, so when a sufficient charge has been received from the timer, it'll trip it, and then that's what terminates your exposure. Okay, the second type is that ionization chamber system. Okay, this is a hollow cell that contains air. It's connected to a timer circuit through wiring. Okay, when the ionization chamber is exposed to this exit radiation, the air inside the chamber becomes charged. Okay, it creates an electrical charge. That charge travels along the wires to the timing circuit, and then the timer is tripped. So the end result is the same. There is a timer that is tripping, causing the exposure to be terminated when a pre-programmed level has been reached. Okay, now the type of AEC used by most manufacturers is this ionization chamber system. Okay, it is made radiolucent so that it will not interfere with any radiographic images. So here is a picture of an AEC, or they're also called automatic exposure devices, AED. AEC and AED are interchangeable. Okay, so with AEC devices, there's usually 2 or more exposure sensors available for control. Okay, you'll see the 3 sensors here. There's usually one in the center and 2 lateral. And you as a radiographer get to select the configuration of these. You can choose just 1, you can choose 2 on the outside, you can choose all 3. Okay? Now, some of the system features that are there is this mass readout. So the actual amount of mass used for that image is displayed usually immediately after the exposure. Okay, minimum response time on your control unit will refer to the shortest exposure time that the system can produce. And most of these modern systems can produce an exposure time in 0.001 seconds. Okay? The backup time, now this is important, refers to the maximum length of time the X-ray exposure will continue when using an AEC system. And again, remember, these are within your control. You can manipulate these factors, okay, the system features. And as a rule of thumb, when radiographs are taken in the AEC mode, this electronic timer should be set to approximately 1.5 times the expected exposure time as a backup timer in case your sensor, your device, your detector fails, and then it will terminate the exposure. Another feature of these systems is the density controls. This is allowing the radiographer to adjust the amount of preset radiation detection values. Okay, each step on the dial will either increase or decrease your optical density or the amount of density on your film. Okay, in addition to selecting the cells, because you get to choose if it's just the center or the lateral or all 3 of those cells or detectors, you can utilize this dial or buttons for density control. And it's usually a 3 to 7 position direction. So and it'll step up your density of your image receptor by 0.1. So you'll have a 0 value, you'll have a +1, a +2, a +3, sometimes up to +7. And then again the other way, -1, -2, all the way to -7. Okay, and this is your density control that you get to manipulate. Okay, now alignment and positioning considerations. It is imperative with AECs that you know how to position correctly. If you do not get the adequate position, the part of your patient over the appropriate cell or detector, your radiograph will not be diagnostic. Okay, that's imperative. So these are set up, these are adjusted to terminate an exposure in the ideal position. So if you have a patient that you have positioned perfectly, your AEC should work perfectly, okay? However, a lot of patient positionings are tricky. And if your patient isn't positioned correctly, you as a radiographer are going to have to determine, okay, which cells should I be using based on my patient's position? Or should I not use cells? Should I use a manual technique? These are things you need to know and take into consideration when you are using an AEC system, okay? So number 1 is select the detector that will be superimposed by the anatomical structure that is of interest, okay? That anatomic area of interest must be centered properly over the selected detectors. So for instance, I'm going to show you on this next slide, if you're doing a chest radiograph, you're going to select both detectors on the outside, those 2 lateral cells. You're not going to select the center one as well though, because otherwise it's going to need adequate penetration of the spine in order to terminate that center cell's exposure. Okay, which is going to result in a radiograph that's way too dark. Okay, you just want to use those outer lateral cells to terminate the exposure when the radiation has penetrated enough through the lung fields. Okay, so number 3, the patient's anatomic area of interest must adequately cover the detector combination. Okay, properly centered and cover the detector combination. Okay, so for instance, would you use a teeny little kid's forearm on top of a bucky with AECs? Not if that forearm is, even though the forearm's properly centered over one of the cells, if it's not covering the cell, it's inappropriate to use an automatic exposure control system. Okay, And number 4, improper collimation may affect the termination of the exposure time. So if you are collimating too open or too narrow, it can affect your exposure time. Okay? All right, here is some examples. On the left is a lung x-ray used on an AEC, I assume Walbucky, of course, okay? And they are using the center cell instead of the 2 lateral cells over the lung fields. And as a result, a lot of radiation had to penetrate through that spine to hit the center cell enough where it tripped the exposure to terminate. As a result, your radiograph is way overexposed, okay? The example for number 2 here is a lumbar spine. The lumbar spine is adequately using the center cell, however, it is not properly centered over the appropriate anatomy. Okay, so they've centered the anatomy incorrectly. So now you have an exposure that is going through just the spinous processes and the fatty adipose tissue, and as a result, it has terminated the exposure too soon. Okay, if it had been, the patient had been moved posterior a bit more so that the thick lumbar vertebra were over the appropriate center cell, your exposure termination would have happened at the appropriate time and you would have gotten a diagnostic radiograph. Okay, so to wrap it up, if a digital image receptor is underexposed or overexposed, the computer will adjust for that exposure error, but your image quality and your patient exposure is compromised. And we've talked about this before, how a digital system will give you a radiograph that looks good, but it's still not the best quality for your radiologist and your patient exposure. Underexposure also may result in the visibility of quantum noise. We've seen this in our lab. And overexposure will increase patient exposure and decrease contrast. Okay, so positioning is essential. It is key in automatic imaging systems. Okay, so these 2 next slides just show you what your AEC response will be if you manipulate some of the features that are on your control panel. Okay. So increasing patient thickness. So say you do have a larger fluffy patient and you put a +3 in your density control. So automatically the AEC responses, the exposure time will be increased. So if you increased your MA, your exposure time will be decreased. If you decrease your KVP, your exposure time will be increased. So you decrease your SID, your exposure time is decreased. And if you increase your OID, your exposure time is increased, okay? So your radiation has to go through that body part, then through air, okay, and then hit the IR and then get tripped by the timer. So it's just a small increase, however, still an increase in exposure time, okay? If the anatomic part has excessive gas, your exposure time is decreased. So now you're going through something that is less dense, which is air. Okay, different types of image receptors. So if you use these systems, the AEC systems are calibrated by the engineers, calibrated for certain types of IRs that they supply usually. Okay, however, if you use a different type of IR, then that could have a exposure taken and you don't think anything's wrong, but your image quality may be affected, okay, because it's not calibrated to that type of IR, okay? Excessive collimation, again, the exposure time might be increased for that. And then your increased density control would have your exposure time increased as well, okay? So do you know all through this here, it's the exposure time is the only thing that the AEC is responding with, okay? That's the only thing the AEC does for you. The technologist manipulates the other factors, okay? The other factors for AEC systems, though, are usually entered by your medical physicist. So they've determined already what the best KVP to use for that exam is. They've determined the best MA to use. They have the SID programmed in there in the system on what to use for that body part. So all of these things they can be manipulated by the radiographer, but in most instances, they're already pre-programmed for that type of radiograph that you're going to take, okay? So the only thing changing on the AEC side is time. Okay, this next slide is altering AEC exposure factors. So notice when you alter MA, KVP, SID, or OID, there's no effect on the film density because the exposure time is adjusted to keep film density constant. Okay, what does have an effect on film density is all things within your realm, the radiographer's realm. So the detector combination, for instance, your part placement is not covering a detector. That's going to affect your film density by giving you either an overexposed or underexposed radiograph. Okay, the type of image receptor, we kind of briefly touched on that. If you use the wrong type of IR that has not been calibrated to that AEC. Okay. Collimation, excessive or insufficient, may affect your exposure time, therefore will affect your film density. And then lastly, density control, the predetermined level of radiation adjusted. So the radiographer can go to +2, and you realize after you have positioned your patient that they're really a -2, and you forget to change that, your density is going to show as a +2. Okay, so you've got to watch what you are doing on your exposure control board. Okay, now here is another step up from a regular AEC system. Okay, this is called an anatomically programmed technique. And what this does is adds another layer of automation onto your AEC or AED system that you're using. And this is a system that allows the radiographer to just select a particular button on your control panel that represents the anatomic area. So there should be a picture of a chest or a picture of a skull or a picture of an abdomen or a picture of a spine, something like that. You just press the button and a pre-programmed set of factors, exposure factors, is displayed. And these are selected for you to use. So once that part and projection has been selected, the radiographer can adjust the exposure factors that are displayed any way you want to, but it has them programmed for you so that you just have to push one button for a chest, and the normal technique for an average patient will present. Okay, and this is an example of a control unit that has anatomically programmed techniques. And you'll notice on that first line, there's a picture of a skull. And then across, there's skull, PA, lateral, towns, axial, sinus, PA, sinus lateral, waters. Okay, so you as a radiographer would get to just press one of those buttons and a technique would present itself. Then you get to manipulate. If you wanted KVP, for instance, to be higher or lower, you could plus or minus that. You could manipulate your MA station. Notice this is 1000 MA station, and it's being taken at 100 milliseconds. Okay, so you can manipulate all these things. You can manipulate which detector or cell in your AEC that you're going to use right here. Okay, this is your small focal spot versus your large focal spot. Okay. This is your table bucky. So things like that. This is called an anatomically programmed technique. And this is part of an AEC system. Okay, we're going to talk a little bit about exposure technique charts. This is in chapter 13 of your Bushong book. And we did not get into this in lecture, so I just want to touch on this for you. Okay. Technique charts standardize your selection of exposure factors for a typical patient so that the quality of radiographic images is consistent. Okay, consistent in the fact that if you have the same size patients, you can use the same technique to get variable or very consistent radiographs for your radiologist. Or if you have the same patient come back a different day with a different technologist, you're using the same technique chart in the same room, and you're going to get a very comparable radiograph, okay? So there's two types of technique charts that we're going to talk about. One is a variable KVP, and one is for fixed KVP. Okay, the variable KVP charts are based on the concept that KVP can be increased as the anatomic part size increases. The main thing with these, and these are not used very much, okay? Not anymore. The main thing with these is that you have to measure the body part, and you need to be pretty darn accurate in your measurements for this to succeed, okay? Because you're varying your KVP and you're leaving your mass fixed. The disadvantages to this is your anatomical part penetration is not guaranteed if you don't measure correctly, okay? If you're just eyeballing your patient and guessing, chances are you're going to be doing repeats, okay? Changing KVP is less effective for a range of procedures versus changing mass, and it's less accurate for part size extremes. So if you have a average patient and you're using 10 centimeter knee and you get a patient that's twice that at the 20 centimeter range, chances are your technique chart is not going to work as well, okay? So that's variable KVP, fixed mass. Now with the variable KVP, they're saying the advantages are it's easy to construct, simple to use. Yes, you just look at the chart, you see what size body part you've measured your patient to be, and you use that technique, okay? And number two advantage is the low KVP level. Small changes in KVP are more effective, okay? But like I said, this is not in general use at all, okay? So fixed KVP, however, is in general, wide use, universal use. Technique charts are almost always fixed KVP and variable mass, okay? So your fixed KVP technique chart has an optimal KVP value for each part that is indicated, and your mass is what is varied as the patient body part thickness varies, okay? The advantages is part measurement is less critical. We don't measure body parts, do we, out there? We're pretty much eyeballing what body habitus your patient has, and that's what you're going to use. Another advantage is increased accuracy with the range of procedures, okay? There's more consistent image contrast and overall quality, and your part penetration is pretty much assured. So you're going to get a decent radiograph as long as you have a mass that you agree with, so you have enough photons, okay? The disadvantages, of course, are optimal KVP values are not standardized. So when you go to a different room, you go to a different hospital, and KVP for a chest in this hospital is 120, and KVP for a chest over there is 95. So it's not standardized at this time. Okay, so how to develop an exposure technique chart. And this will usually be done by a lead technologist with the help of a medical physicist, okay? And it's just taking a lot of phantom radiographs and seeing which one has the best density and which one the radiologist likes better, and that's your baseline. So you select a KVP value, which is appropriate to the anatomic area to be radiographed, and you determine a mass value that produces the desired exposure. You put that in your chart. You up your mass and lower your mass appropriately for the next step of patient body part thickness, okay? Okay, this next slide is radiographic technique and what affects that. Okay, and we've gone through this already. This is just an overview for the rest of chapter 13. So what affects radiographic technique are patient factors. So anatomic body thickness, body composition, is it air, is it fat, is it muscle, okay? Your image quality factors, as you all know, the 4 image quality factors: optical density, image contrast, image detail, and distortion, okay? And then your exposure technique factors are going to be your KVP, your MA, your exposure time, and your distance. Those are the 4 prime exposure technique factors. Your secondaries are your grid ratio, the fast or slow screens, your focal spot size, small, large, and your inherent filtration and or added filtration. Okay, this slide is important. I want you to know in this table, this is showing what's controlling your image quality factors, okay? So optical density is controlled by mass, and we have gone all over that and had labs on how that affects what you're looking at with your optical density. Contrast is controlled by KVP, had a lab on that. Recorded detail controlled by your focal spot size, your small focal spot and your large focal spot size. Small, for instance, is what we use for extremity work because it shows more detail. And I'm going to go over a couple things about resolution here in a moment. And then for distortion, that's controlled by your patient positioning. Okay, very important to know this table. Okay, types of technique charts. Variable KVP, we went over that, where they have a variable KVP and a fixed mass. That is not in favor anymore. We've gone over fixed KVP and variable mass. That is what we currently utilize. That's very widely utilized universally. Okay, there's also a high KVP technique chart. These are for the high KVP exams, for instance, chest x-rays. And also barium imaging. As we remember, we are now at the 120 kVp for all of our barium images. Okay, that would be on a high kVp technique chart. If you had a fluoro room and that's pretty much all you did, that technique chart could be labeled a high kVp technique chart. And then automatic exposure using the automatic exposure control units. Okay, and then we're going to wrap this up by briefly discussing some attributes on how you can tell if you have good recorded detail or spatial resolution. So recorded detail is also referred to as sharpness, definition of your image, spatial resolution, or simply detail. Okay, and you can read about this in chapter 28 of your Carlton book. Okay, unit of resolution is line pairs per millimeter, and that is what you are looking at here on this slide, okay? And it's a radiographic resolution tool composed of pairs of line that are a set distance from one another, okay? And for instance, on the left here, you have one line which is 10 millimeters wide, and then you have a space, which is 10 millimeters, and then starts the next line. So this distance from the beginning of one line to the beginning of the next is termed one line pair. And in this instance, it equals 20 millimeters, okay? So the second example over here is a line that's 5 millimeters wide, and here is the space in between. That's another 5. So from the beginning of this line to the beginning of this line is one line pair, and the distance is 10 millimeters. So one line pair equals 10 millimeters here. So here's another example. We're getting closer and closer. So this is one line pair, and the space next to it. One pair here equals 2 millimeters. This is one line pair equaling 1 millimeter. This is one line pair equaling 0.2 millimeters. And believe it or not, this is one line pair equaling 0.1 millimeters. I can't see that. I've got a bad astigmatism. If you can see that, kudos, okay? But this is how you can measure recorded detail. Recorded detail is measured, the unit of measurement is line pairs per millimeter. And that's important for you guys to know. This is a measurement tool that tells you at which point the viewer can discern the closest pair of lines from each other. That represents line pairs per millimeter reading, okay? Most humans, it's limited to 5 line pairs per millimeter, okay? At the level where each line is 0.1 millimeter wide, a structure of this size supposedly could be easily discerned by the human eye, okay? Digital imaging, recorded detail, or spatial resolution, commonly called spatial resolution, is determined primarily by your matrix size, your pixel size, and your grayscale bit depth. We're in the digital imaging processes now. Okay, so when you're thinking of digital imaging and you're looking for recorded detail, and you know it is determined primarily by matrix size, pixel size, and grayscale bit depth, you are looking at the X, Y, and Z axes, okay, of that digital image. So digital imaging recorded detail most frequently described as spatial frequency, and it can be a high or low frequency. Shorter wavelength signals, which are higher frequency, represents pairs of lines that can be visualized very close together. And this is high resolution. So once again, shorter wavelength signals, which are higher frequencies, represent pairs of lines that can be visualized very close together. This is high resolution. The opposite, of course, is true for low resolution. Okay? A signal that has a longer wavelength represents a lower frequency, pairs of lines that are further apart. That is low resolution. Okay? So I want you guys just to be aware that, and this next slide will show you, be aware the unit of measurement is line pairs per millimeter to measure recorded detail, okay? And that the best spatial resolution out there in imaging is mammography, which can show 12 line pairs per millimeter. So if you go back to this previous slide, 12 line pairs per millimeter, okay? Per millimeter. So 12 line pairs here, we're only looking at one, okay? And then this gamma camera here can show 0.1 line pairs a millimeter. So not good resolution at all. Fantastic resolution in digital imaging, okay? So that's the takeaway from that. So just be advised that you need to know that unit of measurement, and just look at this table and see where MRI hits, see where CT hits, see where your digital radiography hits, okay? Got better recorded detail than computed tomography, okay? Regular radiography, 8 line pairs per millimeter, and then again mammography, highly detailed, 12 line pairs per millimeter. Okay, everybody, that wraps it up for this lecture. I hope you have a great weekend, and I will talk to you soon.